Hey everybody, my name's Steven Salinger. I'm an officer here at the Gonstead Club down in Palmer, Florida, and this is...
I'm Kyle Probst. I'm an officer in training with Steven.
Awesome. So we're going to talk about the lumbar system today and how to integrate the Gonstead system of analysis when we're discussing the lumbar region of the spine. So for a quick review, with every patient that comes in the door, you're going to take a thorough case history. You can get about 80% of your diagnosis or 80% of the information you need from that case history. So it's extremely important to be very thorough, and we're going to talk about that. And then we always use a 5-step system of analysis. So it's visualization, instrumentation, static, and motion palpation. And then we always take x-rays because we always want to see what we're dealing with. And we want to see exactly how a vertebra is, or any joint is misaligned. All right, so whenever we're taking a case history, as the patient's giving us information, the first thing we can start to think about is which system does it sound like this is in, meaning sympathetic or parasympathetic, the two divisions of the autonomic nervous system. The lumbar region is generally going to have more sympathetic subluxation effects. Dr. Gonstead, through all of his millions of patients, found that generally from C6 down to L5 is going to be sympathetic effects, from sympathetic subluxation effects. C5 to occiput, and then L5 down through sacroilium are generally going to have parasympathetic type effects. So L5 being that transitional segment between sympathetic and parasympathetic. All right, so talking about the lumbar region, those are generally going to be sympathetic subluxation effects. So what does that mean? So if sympathetic is your gas and parasympathetic is your brake, and the gas isn't working, you're going to have more brake going on. So generally you might have decreased organ speed, you might have more flaccid musculature in some regions maybe. You can have headaches in the morning. Whenever you get up, the sympathetic system kicks in, wakes you up. If that's not functioning properly, you can generally get headaches very early in the morning, very shortly after waking up, within 30 minutes to an hour. So those are some things to think about whenever you're thinking about which system you're in maybe. Another couple complaints or symptoms the patient might tell you about that can help you differentiate between maybe a lumbar or an ilium is, does it hurt more when you're sitting down or going from sitting to standing? That could be indicative more of an L5 subluxation, or is it hurting more when you're walking? Generally, if it hurts more when that joint is being used, there's probably an issue in that joint. So walking, the ilium, SI joints used a lot more, versus when you're sitting, there's a lot more compressive forces on the L5 region, and that is going to be the cause of that. So those are some different things to think about whenever we're talking about case history. And the last thing I want to mention about case history is, through Dr. Gonstead's work, seeing all his patients over his career in practice, he found trends relating to each symptom vertebra trends. So meaning he found a very common set of symptoms that occurred when there was an L5 subluxation, a very common set of symptoms and problems that occurred when there was L4, and all throughout the spine. So as patients are giving you their history, and you're taking that case history, think about which segment that might be correlated to. It's not to bias yourself and say that's the segment I'm adjusting just because they said this, but it's another piece of data that you're going to use along with the other 5 steps of our Gonstead system of analysis.
Okay, so we've covered case history. Now we're going to move into part 2, which is the instrumentation. So for this region with the lumbars, we wanted to kind of bring the scope prongs in a little bit more, because the nerve root actually exits more closer to midline than a region like the cervicals. So we just want to make sure that our probes are in closer. So when we start scoping, and it's also very important, one of the typical errors that you can make is with raised paraspinal muscles. Steven here has a little bit of hypertonic paraspinal muscles on the right, so it could be easy to not keep the same amount of pressure based off of that different musculature. So you just want to make sure that you're keeping a nice even scope glide throughout and paying attention that you're not letting that musculature affect anything, and that you're letting even pressure throughout and not letting any air in between the scope and your patient. And so we always start off on high, And so we would start up here, make sure the prongs are nice and close. Start going down the spine, and if you get too much feedback, too much noise, you can always switch it to low. We'll start off on high and see how that works out for you. But just make sure that you're keeping even pressure between both prongs and that you are making sure to take into account the different musculature. And when you get a break in the lumbar spine, it'll typically be down below near the last quarter of the spinous process, just based off of anatomy.
Okay, so we've talked about case history, instrumentation, and now we're moving on to visualization. Visualization is done throughout the whole process. It's not an isolated step. We're going to talk about it in one step here, but you're always looking at the spine and the skin and seeing what you see and making note of that information and processing it, and thinking about how it correlates with some of your other findings. So some of the bigger indicators that there's a problem is going to be heat in an area, any skin blemishes in an area, any edema or swelling. Edema is a big one. The body produces edema as a protective mechanism if there's something dysfunctional going on or there's instability somewhere. So if there's edema, there's absolutely something dysfunctional going on at that segment or that region. It's not there for no reason. It's there because there's something wrong going on. So that's a big indicator. We're going to look for any hypertonicity, like Kyle mentioned with instrumentation. You can see it on the big spinal erectors. If there's hypertonicity on one side, there might be, like within a certain region, there might be hypermobile segments in that region, and the musculature is tightened up in order to help stabilize that. If there's any edema or swelling, you can typically see that. It'll be a little pool, a little ring of edema over a segment, or it might be over a couple segments. But then once you get into static palpation, you can move through that edema, see where it starts and stops, and that can help lead you to the right segment. But seeing it is important. Any skin blemishes, if there is pimples or zits or anything going on, that can tell you that there might be sudoriferous changes. The oil glands might be overactive. Moving on to static and motion palpation. So with static palpation, we're going to be looking for, or we're going to be feeling for the edema, seeing if it's pulled in one area or if it's moving through a couple segments. You want to see where it starts and stops. Generally, it'll be right along the spinous or right next to it, along the paraspinals as well. So if you see edema over a couple seconds, you can move your fingers through it and see where it starts and stops. And generally where it ends is going to be the segment, the problem segment. So that's going to be more where you put your focus versus over 2 to 3 segments. Now while you're feeling that, you can also actually feel hypertonicity over the paraspinals. So the paraspinals are not way out here. They're right next to the spinous process. That's where you're feeling whenever we talk about paraspinals. What you're feeling for is one side is going to be much more taut and tight than the other side. That's generally going to be indicating that the spine, the vertebral body has rotated towards that side. So if I'm feeling for the paraspinals and they feel slightly more taut over on this side, that means there might be some slight rotation, some body rotation towards the right side, so the spine has to be rotated left. And these are going to be more taut because the transverse process has protruding these out a bit on the right side. So that's just something to feel for you, and it's another piece of information we're going to use throughout our process. Okay, now we're going to move on to motion palpation, and I want to talk about a couple mistakes people make first, and we can avoid easily. So the lumbar facets are designed specifically to allow lots of extension and a decent amount of flexion, but very little rotation and lateral bending. They're designed for stabilizing. They're not designed for movement like in the thoracic spine where you can get lots of rotation and lots of flexion. They're designed to stabilize. So, talking about the orientation of the facets, if you can see this here, you can see the facets are lined up here. They're almost about 80 degrees facing backwards. So, whenever you rotate the lumbar spine, there's very little rotation and there's very little lateral flexion versus a thoracic spine, you can see there's a lot more rotation available. So the facets in the lumbar spine are set up more like this, so there's very little rotation available. The facets in the thoracic spine are set up more like this, so there's a lot more rotation available. The L5-S1 joint is set up a little bit more coronally versus sagittally, but because of the iliolumbar ligaments designed to help stabilize that area, it's still not going to have very much movement. So how does that translate to actually motion palpating? So there's plenty of room for extension. So if I'm palpating L5 here, there's a lot more room for extension. And L5 moves uniquely, almost closer to C6, where if you move C6, you can. It's a landmark one to palpate because it moves and tucks away a lot farther than C7. So it's an easy one to palpate for that reason. L5 is a little similar to that. It tucks away a little farther than L1 to 4. So as I'm moving into extension, what I'm feeling for is a lack of movement or a delayed movement in the beginning. I'm not saying just, I am paying attention to total range, but the lack of movement in the beginning or the delayed movement is going to tell me that it's stuck posteriorly. All right, so now we've found that. So if we're talking about rotation and lateral bending again, there's very little. So it's already started to rotate and it's rotated about as far as it's going to go. Same on the other side. And then same with lateral flexion. It doesn't take much to get it to move. The common mistake that people make is they're rotating this, doing this, lateral bending here, lateral bending here. So you can see how much farther he's moving. If the hips start to move, you're moving too far. We're palpating the lumbars. That's the only thing that should move whenever you're palpating that. If the hips start getting involved, either they're very fixated and you're moving too far anyways to get them to move. So there's very little movement in the lumbar regions laterally and rotationally. There's a lot more in extension. So just keep that in mind as you're going through your motion palpation. So we've taken a thorough case history. We've used instrumentation. We've used visualization throughout our whole process, static and motion palpation as well. Now the last part and one of the most important parts is X-ray analysis. So whenever you're doing your X-ray analysis, you want to have two films available every time. The lateral and the A to P. The lateral is the most important one if you got to have one because you have to see which segment is posterior. That's the first part of the listing. Without posteriority, you don't have a subluxation. So it's very important to have the lateral to find that posteriority. And you can also see the health of the discs involved. If there's a very thin disc, as they start to degrade, obviously there's something going on in that segment that you need to be more aware of. The A to P is going to help you determine your laterality and wedging. Wedging is important to help. So the A to P is going to help you find your laterality and your wedging. So to determine laterality or rotation, you're going to obviously look at the spinous process from the one above compared to the one below, but also you can use the pedicle shadows to help confirm that. Whichever one is going to be smaller on that side is where the spinous is going to be rotated towards. So we're also, go ahead.
And then, so it's also important to look at X-ray to find if there's any kind of abnormalities. It doesn't matter how good of a motion palpator or static palpator you are. There's no way you're going to be able to tell what a spondy feels like as compared to just a normal vertebrae. You're not going to be able to tell that just from the tips of your fingers. And it's also important to know if they have an extra or they're missing lumbar vertebrae, which is more common than you might think. So it's important to have that X-ray analysis because having an extra vertebrae or having a spondy on L5, that can completely change what you would be adjusting. And it's important to know that because all of the pieces fit together, and having that extra bit of information can really make or break a case with certain patients.
Yeah, that's a great point. And regarding the fourth or the sixth lumbar, if you have a sixth lumbar, somebody's generally going to be a little bit more hyperlordotic in that region because they have to fit another fully formed lumbar in there. So that'll be important, and vice versa with the fourth lumbar, they might be a little hypolordotic. So that's important to know, especially determining in which piece of equipment you might use. So with the knee chest piece, if somebody is a little more hyperlordotic, you might not want to put them on there. You might want to use a high-low instead, because you can control that amount of that amount of lordosis. Typically, the hyperlordotic patients can be a little more uncomfortable on the knee chest, and you're going to have to feed in a lot more, and to the point where it might cause a little bit of pain and discomfort and cause them to react and tighten up. But somebody who's hypolordosis, the knee chest is going to be your friend, because it's going to help get some lordotic curvature in there and open up the joint spaces on the anterior to allow you to make the set much easier. So those are some things to think about whenever you're in your clinical situation thinking about how to take care of this subluxation. Another important reason for x-ray is to see where the scoliotic curve is at, and if there is one. You might be able to palpate it if it's bad enough without an x-ray, but either way, you're still making an assumption or a guess. And we're not trying to guess with anybody's health. To see is to know. So you always want to see where that curvature is at, because you always want to stay on the high side of the rainbow. And that gets into discussing the special listings down at L5, which we've posted a list of on the handout to go with this. So those are some things to think about with x-ray. So again, you always want to take a thorough case history, use visualization, instrumentation, static and motion palpation, and then always use an x-ray. Thanks for watching, guys. Again,